that habit has left us with approximately 900 to 1,000 videos online where you can hear me engaging with audiences of different sorts on these topics. I do maintain a YouTube channel plus a set of systematic course materials, which include exercises, which include slides, example models, all cross-linked with each other. And if any of you are interested in finding out about that, you'll find some references in the Google Drive site associated with this event. I believe the link to that has been provided to people. And I believe also you've been provided with the link to which on YouTube I'll be putting a lot of the materials that will be, a lot of the discussions taking place this week. Okay, so if it's okay with you, I think we'll get started with this initial components. Apologies, I had to set up this the computer to work with this screen properly. I'm going to go through a whirlwind tour of what is simulation modeling and why does it offer potential value for health and healthcare. This is going to be a whirlwind tour, and I'm a great believer in the notion of spiral learning, and we're going to see over the next day or so a lot of that applied here. Many of the things you hear me talk about today will be presaging material I'll be presenting in coming days for a reason. I'm going to hope for getting a sense from the audience of which things I discuss are of greatest interest. So it does put a premium on you speaking up, asking questions, and indicating which of these topics you find most interesting. So we'll go around at a very, very high level as today's schedule forces, and then we'll go into more detail about certain topics that I touch on today. In terms of broad outlines, my colleague Bobby Milstein in the States speaks about public health as seeking to redirect the course of change in terms of the health of populations. And it's a difficult challenge often. I show here rates of incidence rates associated with sexually transmitted infection, Chlamydia, which is one of the areas in which we've worked over the years. And what you see is a general downwards trend in the 90s that was heralded as a public health success. A great sign of progress in terms of faster diagnosis, more effective contact tracing, improved treatment regimens, better understanding how to keep this really nasty communicable illness at bay. And at the time, there was a lot of well-deserved backpatting that went on. But a few years later, the situation seemed totally different. Just in the early years of the 2000s, there was a lot of talk about a crisis that had befallen us. Unprecedentedly high rates of reported cases of chlamydia were being recorded in city after city, in province after province of Canada, and indeed in country after country across the industrialized world. And there was a lot of consternation. What's driving these rates? What underlying factors are leading to the cases rising so quickly? And what can we do to turn that around? Over time, there was an additional set of voices that spoke up and actually asked, to what degree is this really a crisis? And to what degree is this actually reflective of better and better case finding? To what degree is it reflective of the fact that we can diagnose people more broadly, people we would have missed, and therefore the higher reported rates are not a sign of higher true incidence rates, but instead an artifact of our case finding. They're not a crisis, perhaps, but a sign that we're draining the swamp. There were many hypotheses driven forward. I think we recorded 7 of them in the literature that were all aspiring to reason about why these rates rose. But all people agreed that what mattered at the end of the day was to take evidence like this and turn it into actionable priorities and decision-making within the public health sphere. The diverse different voices were arguing from very different perspectives, but all shared that sense that, we need to make better sense of these data. We need to take this evidence, better align it with our understanding of what's going on in the world. And it's really for that purpose that we turn to models. But the world is a complicated case. If you look at areas like diabetes and obesity, where for a long time, there, in the biomedical perspective, there were some clear causal relationships, some clear risk factors that told a story, that weight leads, higher weight, particular central adiposity, increases risk of developing diabetes. If you unpack it, what you find is it's tangled and tied up with a wide variety of conditions, which are everything from simple epidemiological relationships concerning the implications of risk factors such as genetics on the one hand, to factors such as weight and history of exposure over time. Two factors that involve components of family context, involve the social environment, the physical environment, involve even factors such as the availability of food, the food distribution network, agricultural subsidies that subsidize high sugar beverages, and we find that it's increasingly tied up with a broader set of societal factors that are more and more difficult to grapple with. So we have obesity as a risk factor, but a set of regulatory processes that go on with each of us. We have diverse actors in the form of the food industry, agricultural industry, factors having to do with different players in the marketing sphere, lobbyists who are pushing for certain types of agricultural policies, and the roles of various types of nested environments. We have different attitudes, norms towards weight and towards diet, as well as physical activity and sedentary behavior, which are all believed to play significant roles. And then we have interactions with other conditions that were traditionally viewed as very distinctive and separate. Things like gestational diabetes closer to home, things like the metabolic syndrome, which has a constellation of factors associated with it that transcend any one chronic condition. And increasingly, there's discussion about gene by environment interaction, the effects that exposure to certain environments may cast a long shadow on the life course by predisposing expression of certain underlying genetics that otherwise wouldn't be expressed, and thereby changing your health trajectory. We see similar complex sets of factors within the oral health area. We can tell narratives that start very simple. The dentist just pulled my tooth because I suffered from an abscess. But if we unpack that, we find what's driving it gets more and more involved and more tangled. Again, involves aspects of the family environment, the fact that we have different levels of presentation for care reflective of barriers such as physical access to a facility, such as the availability of that facility in terms of the hours at which they operate, the accessibility culturally of facilities. This is a really big issue in some areas of the states, and the fact that facilities may be very expensive for large portions of the population, and therefore they present for care only in emergency situations. We see the fact that many families struggle to make ends meet, and even simple investments in hygiene are not within their educational exposure and not within their easy access in terms of the economics. We see that it's tied up with the food environment, which once again has a wide variety of issues affecting it. So here we have a variety of biomedical factors, such as abscesses caused by oral bacteria and dynamics of tooth decay, but also factors such as hygiene, which are recognized as risk factors, but aspects of the care environment, the availability of accessible care, and the fact that many aspects of tooth decay depend on an individual's context in the form of transmission of bacteria, in the form of the food environment provided within families, and within the broader environment of marketing. So we have these different layers of context. And if we really want to change the situation, as Jeff puts it, if we want fixes that stay fixed, the traditional solution of drill and fill is not going to be effective in the long term. You take a kid exposed to an adverse food environment, exposed to a family environment that's struggling to make ends meet and where they don't have coverage for dental care, and you drill and fill their tooth, and you give them a toothbrush to go out, you're throwing them back into the sea to drown once again, and they're going to be back once again. You're not changing the situation in a sustainable, consistent way. You start to talk about more upstream factors, and you start to be able to think about nudging it more effectively. Talk about behavioral counseling to help for basic education on the hygienic side. You talk about efforts to subsidize the ability to present for care on a regular basis, reminders. You start to work upstream, and that's where things might start to stick. But there's a lot of questions about how do we go about understanding these components of the situation to help us prioritize our investments in areas such as this. And I could go on. There's dozens and dozens of challenges within the public health sphere where we have a similar set of factors, heart disease and tobacco. My colleague Sandro Galea has presented narratives there and has noted the wide variety of environments. Now, many of you will recognize pieces of this, and indeed in the sort of traditional reductionist approach to understanding health challenges, there's been great studies undertaken on many components of this. We understand the pieces of the system really well, but understanding how they fit together, how they interact to yield the adverse health circumstances we see, and most importantly, how they mediate the effects of interventions and affect their effectiveness, their efficiency, and the time with which they have effect, are a lot of the factors that are not really well addressed by traditional techniques. So we have profound insights on the mechanisms, on the particular pieces, but we have a lot less understanding about how they fit together, how the family environment combines with the physical environment, combines with the social environment, combines with the environment informationally, combines with these biomedical factors to shape these outcomes. And if we're seeking to reliably understand policy trade-offs to remedy these health burdens, if we're seeking the ability to reason about the impacts of novel interventions, which have never been seen before, and to in fact design those complex interventions, and if we're seeking to help understand the link between what's known at the micro level and what we see at the macro level, we need to turn to other techniques. Making decisions will be risky and uncertain absent insights how these pieces affect the whole. And here we are seeking techniques that help us design fixes that stay fixed. So, you know, my colleagues within the public health space, this from Sandro, now Dean of Public Health at BU, mapping out the food environment, all its tangled interactions. Shariki Kumnaika, another colleague of mine from Network for Inequality Complexity of Health, like Sandro, has mapped out the different nested levels of the environment affecting obesity, which is mind-boggling in sort of the levels of context. And others at the Foresight Institute in England have systematically partitioned out factors in their interactions that they believe are causally playing a role in contributing to development of or maintaining of the epidemic of obesity we see across much of the world. But all of these factors are steps towards a broader understanding that we are seeking of the whole, of the whole picture, rather than the individual pieces of the picture. What we see in the complexity science area is that interaction of very simple components that are independently unsurprising can lead to very, very surprising high-level patterns that arise. These patterns that we see at the public health level cannot be merely reduced to any one piece of the system and transcend those pieces, but they are in some sense the results of the interaction of those pieces and what we call emergence, through a process we call emergence, the emergence of surprising high-level patterns, not reducible to those pieces. And we're seeking ways here of understanding systematically how the behavior of the whole arises from that of the pieces, so we can often change that behavior, so we can nudge it towards a more favorable outcome. So, for example, understanding the effectiveness of a drug or weight loss regimen or the effectiveness of tobacco cessation as measured through clinical trials, we know these days contributes only partial knowledge to understanding its effectiveness in the population. Increasingly, community-based trials are seen as essential for understanding the true underlying possibilities associated with a new health technology, because we know that in clinical trials, we control for many of the key factors that are going to be shaping its effectiveness within the broader population. You know, understanding caloric expenditure at physical activity at the micro level doesn't necessarily lead to an understanding of how certain levels of enhanced physical activity will translate into weight loss, because it affects other things, such as nutritional intake. It involves a lot of physiological feedbacks that may make the body more efficient when losing weight, etc. So in case after case, understanding the pieces does not translate to an understanding of the whole. And people have long noted, going back centuries in certain areas of health, patterns that are puzzling, structured, yet not obvious where they come from. This from recorded deaths from bubonic plague in the early 1700s in London, the cycles that we're seeing in patterns of childhood illness, and sort of outbreaks of things such as measles, chickenpox, varicella, and in the context of whooping cough. These factors are not merely of intellectual curiosity. This great complexity is not merely a factor that is intriguing from a scientific perspective. It really matters in terms of potential policy outcomes. We know that in certain systems there are tipping points. If we can invest just enough within the system, a little bit more investment can make a marked difference, can qualitatively change the situation to the better. We know that if we can get a system to that point where we can cause one of these tipping points, we may go from a situation where we're constantly fighting fires, constantly on the defensive, to a situation where we're flying ahead of the plane and able to affect reliable planning for the long term that keeps the system under control. Think about this in the context of a dementia ward, or you can think about it in the context of an STI in the population. There's many factors which have these tipping points associated with them, many contexts. So within the policy context, we're seeking this ability to anticipate what these tipping points might be, to anticipate where the high leverage points might be in nudging the system. And we see elements of the system that point us to opportunities in many components. One is the presence of path dependence. The fact that intervening early and intervening in the right way early in life can make a world of difference on the trajectory that a child follows into adulthood and later on through life. We know from Barker's work in the UK, looking at the long-term impact of adverse childhood experiences, about the lifelong shadow that they can cast. And by contrast, we know that our early investments have potential huge opportunities. The question is where to invest most effectively and how to bring to the table strong evidence to this effect. We know that in many contexts we're shaped by our networks. Frank Lloyd Wright once said about buildings, we build our buildings and then our buildings build us. And so it is with our social context. We select our companions, we select our colleagues, we select those with whom we can associate, and for the rest of our lives, often they end up impacting our health-related behaviors, norms, attitudes, etc. And understanding these network structures can often be key not only for communicable diseases like TB, where we've done a lot of our work, and where bridging individuals between communities can form a key focus, or other diseases where network cores, such as STIs, make a big difference, but can have a broader impact in the chronic disease space as well. In some contexts, the population is such that a small subset of the population, these individuals in the core network at STIs, for example, have a disproportionate impact on the behavior of the system as a whole. Can lead to an infection that would otherwise die out in the population, staying resident and affecting people throughout the population. Here we have a situation of the tail wagging the dog. Just a small segment of the population can have a disproportionate impact. And some have somewhat controversially pointed to similar phenomena that may be playing in, for example, weight change within populations. We see big geographic disparities with chlamydia, for example, here in our province, or gonorrhea and chlamydia elsewhere within Canada, the spatial spread of diseases such as rabies. These are complex challenges that confront us. These patterns are difficult to grapple with, and when we're considering our intervention options, often they bedevil our attempts to change things. So we get counterintuitive behavior out of the system. We invest in low-tar cigarettes in the 1970s in the States with an expectation of large gains in terms of the health, and we find that they've done net harm. Rather than simply leading to less exposure among those who smoke, they end up lowering quitting rates, so more people stay smoking. They lead to misperceptions, cases where something is viewed as a crisis that's actually an opportunity, something where we misperceive the nature of something that's driving an adverse health trend, and we end up investing in the wrong response. And they lead to policy resistance. We have an investment in a health policy that ends up going wrong because it's diluted, or it leads minimal or even adverse health outcomes. And there's a long litany of failures within the health area where things that were heralded as potential grand successes, but were not thoroughly thought through from a systems perspective, ended up yielding adverse outcomes. Some cases here from the North American context are given, and I'm sure there's similar contexts worldwide. We also see cases where we can have disproportionate impact if we just know the right time or the right place to intervene. We talked about tipping points earlier. And all of these factors pose real problems for learning from experience, for translating a gain in Sydney into a gain in Adelaide, for coordinating different parties within a healthcare system, coordinating the social services side, coordinating the folks from the educational side, coordinating the folks from the criminal justice side, and all keeping kids safe within the educational environment and within school. They raise problems for planning and deciding. It's not clear when we're faced with this cacophony of challenges what the best trade-offs are between choices, and it's not clear how to design a new system more effectively. So we end up falling out of a window and being booted into to new fire, and we end up railing like King Canute against the rise of the tide and working against the nature of things in our policies. We're seeking a way, like King Canute, to work better with the natural cycles that are out there, with the natural ways in which factors in the world work. But to do that effectively, we need to understand how it is that these patterns are resulting from underlying drivers. So the reflection here is that these patterns we see, these patterns associated with complexity and outcomes at different levels of a health and healthcare system, are reflections of certain underlying processes, certain latent processes that are often not directly observed or little observed. They're tightly interrelated and causally tangled. They don't obey any neat distinctions between the biomedical domain and the domain of the social sciences, for example. And to really understand why these patterns persist and why they resist efforts to correct them and how we can most effectively ameliorate them, we need to reason consistently about these processes that are giving rise to them, how the world works. We need to reason about sort of the nature of things out there so that we don't work at cross purposes with it. And this is really the broader goal of systems science. It's the science of the whole to help us understand how these high-level patterns reflect the complex interaction of factors and how we can change those factors to most favorably affect the behavior of the whole. So system science provides a variety of techniques, and we'll be talking about 3 today, to visualize, understand, and reason about implications of these underlying processes. And a key component that we're going to be emphasizing this week is through the use of dynamic models. We'll be defining a little bit more what's meant by a dynamic model, but these are models that help us reason about how things work within a system in a consistent way, help us air our hypotheses, put them on the table in an explicit way so we can critique them, refine them, advance them, and make better, quicker, and deeper use of the evidence that's available to us. So these models think as thinking tools, laboratories for refining our thinking. They help us share our assumptions and refine them with others, and they help us reason consistently about the implications of our assumptions. Okay, let's talk a little bit about these dynamic models and what they look like, and we'll be seeing some examples. So simulation models are one term for dynamic models. You'll find many others. Dynamic model is a common term. Causal model is used increasingly confusingly in several different areas for different types of models. This is one of them for one segment of the community. Mathematical models is another term you'll hear quite often. Compartmental models are an example of this. Microsimulation, agent-based models, discrete event models. You'll find them go by many different terms and guises. And if you want to do a literature review in this area, you'll be advised to deal with this cacophony of different terms. These models provide a way of examining system-wide consequences of changes in one or more area of the system. And they help us understand system vulnerabilities, leverage points, ways of changing the system structure, and improve ways of working together. We're going to be concentrating on one particular use of this model most significantly within this week, serving as what-if tools for identifying desirable policies. Policies that are cost-effective, that are high-leverage, that are robust in the context of the uncertainties that confront us. But they can be used for a wide variety of other needs. Perhaps most fundamentally, they make explicit our assumptions in a way that takes them out of our head and puts them into a form that can be examined by diverse parties and refined. And they can serve as communication tools. My colleagues Josh Epstein and Don Burke at Pitt, Josh is at Hopkins, have gathered dozens of uses of models of these sorts. And if anyone's interested in learning more about them, I would refer you to that literature. Suffice it to say that they're valuable assets, whether you're trying to decide what data to collect, whether you're trying to figure out in what interventions to invest, or whether you're trying to make sense of data as it's observed. So these models basically depict the behavior of a system over time. They feature evolving state, a depiction of kind of the current situation in the population right now, and they help see how that state changes over time. The models themselves don't dictate how that will change over time. What they talk about is they describe how the system changes in an incremental sense over time, and a simulation package will total that up to yield overall behavior of the system. So we specify how the different pieces relate to one another and how they work, and it takes care of kind of knitting them together to understand the behavior of the whole. These are models that capture hypotheses about how the system works, and often we'll be pursuing several models in tandem, which represent competing sort of ideas about what might be going on. Here, we can use those models to check the consistency of our understanding as captured by the model. This theory building we do with models, we can use it to compare with empirical evidence. And generally, these models, like the systems that they characterize, are nonlinear. They exhibit a situation where the whole is greater than the sum of the parts. They exhibit counterintuitive behavior. The response to several interventions is often very different. As several interventions put together is different than the sum of the responses to each intervention in isolation. They exhibit history dependence. A change in one area may affect lots and lots of future components of the system in a ripple out sort of way. And they can exhibit lock-in effects where you can get stuck in an adverse situation or stuck in a positive situation. And you can have disproportionate impact of certain subgroups. I'd like to analogize these models to maps. You could say at a certain level that maps, while we use them day to day to very good effect, they're all wrong in the sense that they're all abstractions. They're all simplifications of the world. They help us navigate through the world in very useful ways, but they're useful precisely because they omit details. They're useful because they take a lot of details and hide them that are not directly germane to our needs, and they bring out certain details. So if we wanted to drive through Adelaide to go from the airport to here in the central business district, we would make use of a street map that's very different from a map that someone investigating flooding challenges would need, or just dealing with brownout issues, or dealing with grading of streets, which might be topographic or might be focused on the hydrology of the region. So what details we omit depends on how we wish to use these artifacts. And so it is with models. Models are simplifications that help us navigate the world in a reliable way while avoiding overwhelming us with details. The only perfect map of the world is the world itself, and the only perfect model of the world is the world itself. Models are useful because they simplify. With models, there's an additional challenge that it's often a little bit harder to figure out ahead of time what things are important. So whether you're dealing with a system dynamics model, an agent-based model, a discrete event simulation, micro-simulation, there's going to be a common set of questions. And one of the most fundamental concerns model scope. What's in the model and what's left out? Given that it can't represent all details, what lies within it and what lies externally? Well, here we make a distinction between three different levels of inclusion. And some set of factors are what we call endogenously simulated. They're actually incorporated in the model, so the model tries to calculate them. Maybe this would be the number of people who are beset by dementia within a population or within a certain subpopulation. So it would be the occurrence of dementia. Maybe it will be a factor associated with development of a certain mental illness. This could be something that the model would aspire to produce by running it. It would generate sort of estimates of how that might be changing over time. And these are often quite central to the goals of the models, the factors that are endogenous. They're more important for the model to reason about, and they often both are results and a contributor to the model. They both are an output and an input, you could think, on an ongoing way to model evolution. By contrast, there's a set of factors that are often represented within the model in what we call an endogenous fashion. By exogenous fashion, they're pre-specified. You put them in, it has a representation, perhaps, of the availability of mental health services, or representation of the level of truancy in a school. But it's not, the model's not trying to calculate it. Finally, there's a set of factors that are ignored by the model, that are simply left out of it. Hopefully we do that consciously. We know that it's not in the model. We know that the model does not yet include these factors, and we make note which things are ignored. This is one of the most important divisions when building models, to delineate these factors, and it evolves over time. As a model matures, factors that were previously ignored may become exogenous. Factors that were exogenous, represented but not resulting from the simulation, may end up becoming endogenous. They may be endogenized to capture the impacts of interventions on them, rather than just specifying what they are over time in some fixed fashion. generally capturing more factors endogenously, capturing truancy, for example, as an endogenous factor of the model rather than an exogenous one, might allow us greater flexibility with the model to investigate certain types of interventions. We might be able to more accurately increase the model's accounting for certain patterns in the population, but it also requires time, greater amount of resources, greater knowledge to bring to the table. Okay, I think now I'm going to be finishing up soon, but I want to provide a brief glimpse of system science model to give you some flavor of what we're dealing with, bearing in mind that starting tomorrow, we'll be going through quite a few hands-on exercises that will expose you to these step by step. The first of them is the system dynamics approach, which is a feedback-oriented perspective to modeling. It focuses on these cases where a change in one part of the system can ripple around and either amplify or push back against that original change. So, for example, falling into poverty due to the loss of a job may lead one to lose ready access to transportation, which further limits your job options, which makes it even more likely that you'll be unemployed down the road. This is an example of a feedback. Or it may be that there's a virtuous feedback, providing a child with the opportunity to go to university who otherwise wouldn't have it, may give them a leg up on their career, which gives them social capital, which brings educational resources, and which allows them to further their career yet farther. System dynamics is an attempt to help conceptualize, describe, analyze, and manage feedback-based systems that puts these feedbacks at the centers of it. And it's distinguished within the context of these sorts of modelings by really its emphasis on qualitative and quantitative components, and its emphasis on participatory modeling, modeling that involves stakeholders. It's also notable for having a really rigorous mathematical foundation that affords us the chance to reason at a mathematical level deeply about a model's possible behavior over many scenarios. Now, I don't have time to go into this. I do want to get you folks to a break, but I will note that system dynamics tends to focus very assiduously compared to other techniques on a very important deliverable that transcends the model. The model itself that comes out of a system dynamics investigation offer delivers value. It's an artifact that you can use to run scenarios and examine things. But within system dynamics, there's a great deal of attention to the mental model as the prime deliverable, changing how people think about the system, changing how people conceptualize their role within that system. Think about one set of stakeholders working at cross purpose with another, potentially changing that role to realize they have to work together to really accomplish each of their goals. They're not going to be able to sustain their goals by working at cross purposes. So system dynamics tends, as an approach, to really emphasize changing how people think within the system. And it points to diverse cases of adverse policy resistance as an indication of cases where mental models were not changed. So within the system dynamics context, there's a strong emphasis on sort of the modeling loop with initially qualitative models leading to quantitative models, leading to observed model behavior, which refines the mental model, and leading to interventions in the world or collection of additional data that further refines that model. All of this often within a participatory space where it's not just the modeler, but those in an interdisciplinary team with whom they're working. I would love to talk more about this, but because of the time, I'm going to have to skip on to the next approach here. We'll come back to the issue of system dynamics and take a detailed look at the meaning of some of these boxes and the arrows between them within a later discussion. Within the context of system science techniques, I want to draw the attention to a second technique known as agent-based modeling that will be occupying us for much of this week. Here we're simulating at an individual level one or more populations. And we're characterizing for each member of those populations an environment in which they're located, often spatial or topological, so they can be situated in a building, or they can be situated within a geographic space, or embedded in a network reflecting sort of a set of services that are affiliated for children with developmental disabilities or what have you. And each of these agents, whether it's a person or a service, is associated with certain parameters, certain assumptions at an individual level that are typically changing, not at all or only infrequently, things like gender, ethnicity. They could be discrete or they could be continuous, things like birth weight or income. Some state of that individual, their current situation with respect to perhaps job seeking, whether they're employed or part-time work, full-time work, whether they're engaged in education, or whether they're unemployed, or it could be a health state. They're currently in a pre-diabetic state, or they have frank diabetes, or what have you. And finally, a way of evolving that state and a means for interaction with other agents. There's a time horizon. We run this model forward over time from some initial state. And as for the case for system dynamics, I don't have time to go into this in detail, but I would note that within the population, we design a description of a set of individuals. We associate them with the population, and then we can associate them with these parameters, things like ethnicity, sex, and income. And when we run the model, each person will be associated with very specific values for those parameters. We associate them with some state by which they evolve, perhaps with respect to some health condition, and it may be more than one sets of possible states. This, for example, involving care seeking, on the left involving health states, and they can interact with other individuals, for example, through a network. From these sorts of models, when system dynamics, we see patterns over time. Here we see patterns over time, but also over space. For example, it's a model of a prion-based disease. I understand Kuru is one thing that's seen within the Australian context that is prion-based. In Canada, we have a number of prion-based diseases. This for chronic wasting disease. And you could see that there's emergent patterns of distribution of prion, shown in red, from these deer as they circulate within the population. We may see patterns associated with the spread, for example, of new norms, attitudes, beliefs within a population spatially, or within the context of a network, individuals in denser, crowded situations being more exposed to communicable diseases. In contrast to system dynamics models, which are deterministic, which run and get one outcome for a certain set of assumptions, within the context of agent-based modeling, we have stochastics. We have uncertainty over time. And as a result, a given intervention doesn't yield one outcome. It yields a distribution of possible outcomes. And we can map those out. And we can map out, for example, for different subsets of the population, what's a gain associated with an intervention. Within agent-based models, one of their key attributes is that they can allow us to delineate factors at different levels of scale. For example, we could have multi-scale models where we can capture cities, and each of the cities will have dynamics associated with it, and there may be connections between cities. Or perhaps these are farms, and you're concerned with the spread of an illness between herds on farms. Or perhaps these are service networks, and you're looking at the innovation of diffusion of ideas across different service units within a state's healthcare system. So agent-based models carry a number of strengths associated with capturing network and spatial context, multi-level nesting, capturing situated decision-making by individuals within a certain local context, capturing heterogeneity, it's one of its great strengths, and longitudinal information at the level of an agent. Their episodes of care, their history of exposure to a certain infection, their history of exposure to services within the population, education, etc. And we can have very compelling visualizations that relate them to geographic services. The final type of modeling I'll just briefly introduce you to, bearing in mind we'll be seeing all of these more, is the discrete event modeling. This is process-centric modeling, where we're focused on a set of workflows associated with processes that are fairly well delineated. Perhaps these are processes associated with the intake of a patient in a clinic for outpatient care. Perhaps these are stages within the handling of a person as they present for vaccination. Here, we have a set of processes that are shown in a workflow in a very visual way. We have resource constraints associated with their processing of these individuals according to resources that might vary from fixed components, such as operating theaters or procedure rooms, to availability of clinicians or beds and equipment, more passive resources